Hello, my name is Brittany Schmitz. I am the researcher of this study. This is the assessment of revised emergency department stroke protocol. Acute cerebrovascular accidents, commonly termed as strokes, are a common occurrence, with one occurring in the United States every 40 seconds, and approximately one person will die from a stroke every 4 minutes. Worldwide, 15 million people suffer from a stroke yearly, 5 million will die, and 5 million more will be left permanently disabled. In the United States, strokes are also the leading cause of severe long-term disability, and the time between symptom onset and treatment can determine the patient's level of disability post-stroke. Approximately 87% of strokes are ischemic strokes, which can be treated with tissue-type plasminogen activator, also known as TPA. The time limit to give TPA is less than 3 hours after symptom onset in most patients, and up to 4.5 hours in some patients. The American Heart Association, American Stroke Association's Target Stroke Initiative has set a goal of at least 50% of ischemic stroke patients to receive TPA within 60 minutes of their arrival to the emergency department. The time between symptom onset and treatment can determine the patient's level of disability after a stroke, and earlier administration of TPA has been found to lower in-hospital mortality and intracranial hemorrhage, and increase the percentage of patients who are discharged home. More than one-third of acute stroke patients fail to utilize ambulance services. This can further increase the time between symptom onset and treatment because patients who do not use ambulance services are delayed in getting to the emergency department. The emergency department does not receive pre-arrival notification, and the patients may arrive at a non-stroke center emergency department. Non-stroke center emergency departments are at a disadvantage when it comes to stroke care. The facility of this study is a non-stroke center emergency department. Along with the disadvantage of not receiving pre-arrival alerts for patients who present to non-stroke center EDs by private vehicle, non-stroke center emergency departments have less experience in recognizing acute strokes and less experience in treating acute strokes. It has been found that hospitals with less experience treating acute stroke patients have been found to be less likely to administer TPA within 60 minutes of the patient's arrival to the emergency department. This can be due to various reasons, including lack of stroke teams or stroke protocols. Stroke protocols are set in place to help facilities achieve door-to-TPA time within the recommended 60 minutes. Each facility establishes their own protocol for stroke patients. The literature review revealed the 12 key best practice strategies of the American Heart Association's American Stroke Association's Target Stroke Initiative. Each study of the literature review utilized some of the 12 key best practice strategies. Which strategies were used were based on the resources of the facility of each study, so not every protocol is the same. The 12 key best practice strategies are EMS pre-notification, stroke tools, rapid triage protocol, and stroke team notification, single call activation system, timer or clock attached to the chart, clipboard or patient bed, transfer directly to CT, rapid acquisition and interpretation of brain imaging, rapid laboratory testing, including point-of-care testing, mixed TPA ahead of time, rapid access and administration of TPA, team-based approach, and prompt data feedback. As mentioned earlier, the 12 key best practice strategies are utilized differently in each facility. The stroke protocol for the study, Advani et al., consisted of pre-notification from EMS, single call activation to call the stroke team, which consisted of the neurologist, radiologist, and 2 nurses. Labs were obtained before CT. CT was then obtained, and then TPA was administered in an ED room if indicated. The stroke team at this facility reduced the door-to-TPA time from 75 minutes to 31 minutes over a 3-year period. The stroke protocol of the study, Zinkstock et al., consisted of pre-notification of EMS arrival, single call activation of the stroke team, pre-registration of the patient so that the CT and labs can be ordered ahead of time. EMS gathers patient history, medication use, and point-of-care glucose while en route to the hospital. The patient is taken directly to the CT scanner. The CT is obtained, and the radiologist performs a live read of the scan as it is obtained. The patient is then taken to a dedicated room where the patient is placed on a bed that can weigh the patient. A point-of-care INR level is obtained if the patient takes anticoagulants. Labs are then drawn, TPA is prepared, and administered if indicated. If intra-arterial therapy is considered, the patient is taken back to CT for a CT angiogram while the TPA is infusing. The stroke team at this facility was able to reduce the median door to TPA time from 75 minutes to 28 minutes with the revised protocol. The stroke protocol of the study, Ajmi et al., consisted of pre-notification by EMS through a dedicated stroke thrombolysis alarm. Patient is prepared during transport, which consists of obtaining patient history, anticoagulant use, symptom onset, weight, peripheral intravenous access, and blood pressure monitoring. The patient is taken directly to the CT scanner. Lab draw is delayed until after TPA administration if the patient is not taking anticoagulants. The patient is examined and administration of TPA occurs while the patient is in CT. CT angiogram is obtained while the TPA is infusing. The stroke team of this facility was able to reduce the median door to TPA time from 27 minutes to 13 minutes. As you can see, each of these protocols is slightly different depending on the resources of the facility. In the study, Advani et al., labs were obtained before CT, but in Zinkstock and Amji et al., the labs were deferred. Amji et al. Only waited for lab results if the patient was taking anticoagulants, and Zinkstock et al. Utilized point-of-care INR testing for patients taking the anticoagulants to reduce the delay in TPA administration. Another difference is that the stroke team of the study, Amji et al., administers the TPA while the patient is in the CT rather than waiting for the patient to be taken back to a room. Another difference found in some stroke protocols was that the CT angiogram was obtained prior to TPA administration rather than during TPA administration, like Amji et al. And Zinkstock et al. Theoretical framework. Ida Jean Orlando's deliberative nursing process theory consists of 5 stages: the assessment, diagnosis, planning, implementation, and evaluation. The nurse first assesses the patient by considering the reason for the encounter, as well as subjective and objective data to determine the patient's needs. The diagnosis stage occurs by the nurse using clinical judgment based on the data gathered about the patient to determine a possible medical diagnosis. The planning stage sets a specific goal or outcome for the diagnosis that were identified. During the implementation stage, the nurse begins using the care plan that was established during the planning phase. And finally, during the evaluation phase, the nurse assesses the progress of the patient towards the goal and determines if the care plan should be continued or changed. According to Ida Jean Orlando's deliberative nursing process theory, all patient behavior, including verbal and nonverbal, is a cry for help, and it is up to the nurse to determine the needs of the patient. Stroke symptoms can range greatly from patient to patient, and many patients do not understand what is happening when they present with acute stroke symptoms. Some patients may also have difficulty describing what symptoms they are having due to expressive dysphagia, which can be a symptom of an acute stroke. Due to this, nurses must be able to quickly assess the patient and determine the possible diagnosis of an acute stroke when a patient presents to the emergency department. With the establishment of a stroke protocol, which is used with all acute stroke patients, the nurse can quickly implement the nursing care plan for these patients. The planning stage may not be needed because the stroke protocol has already been planned ahead of time to ensure rapid implementation. During the evaluation stage, the nurse can then reevaluate the progress of the patient and determine if the care plan needs changed based on the progress of that specific patient. Some methods for this study. The purpose of this study was to determine whether an updated emergency department stroke protocol would improve the critical care time of stroke patients. Critical care time is the time from arrival to ED to stabilization of the patient. Stabilization is the time when the patient can be monitored remotely with minimal direct physician or registered nurse observation or interventions. As the researcher, I hope to determine whether a revised stroke protocol would improve the critical care time and reduce the assessment, stabilization, and treatment time of patients with a suspected acute stroke because early recognition of symptoms, early interventions, and early treatment reduces post-stroke disability and mortality. The revised stroke protocol attempted to improve the areas that caused delay in the previous stroke protocol and focused on a rapid patient assessment, rapid acquisition and interpretation of the non-contrast CT head scan, and rapid administration of TPA when indicated by utilizing a single call activation system and a team-based approach. The revised protocol attempted to improve multiple areas of delay which were present in the previous protocol. These areas of delay included going to a regular exam room instead of the resuscitation bay, waiting for the physician to assess the patient, drawing labs and doing other interventions before CT, and waiting for lab results and official radiology reports of the CT scan prior to TPA administration. The following is a summary of the revised protocol. First, a code stroke is activated for patients with an onset of symptoms less than 24 hours prior to arrival. An overhead page is announced in the ED. The patient is then taken to the resuscitation bay for a rapid neurological exam and a point-of-care glucose test. The patient is placed on the cardiac monitor if time permits, and no other interventions are completed at this time unless the patient is unstable. If the physician determines that the patient is having an acute stroke, the neurologist and radiologist are paged. The CT technician will prepare the CT while the patient is being rapidly assessed. Then the patient is brought to the CT within 10 minutes of arrival. The registered nurse who was assigned the role of scribe monitors the time to ensure that arrival to CT occurs within 10 minutes. The ED physician performs a live read of the non-contrast CT head scan as it is obtained, and if indicated, peripheral venous access is obtained while the patient is on the CT table to obtain a CT angiogram of the head and neck to assess for large vessel occlusion. Labs are drawn at this time. The patient is then brought back to the resuscitation bay after CT to perform other needed interventions and administer TPA if indicated. This research study used a descriptive correlational design and included a retrospective electronic medical record review. The setting for this study was an academic safety net level 1 trauma center ED that was located in a large metropolitan area. This setting was not a stroke center. This emergency department consists of 48 patient beds, 3 of which are trauma resuscitation bays. This ED cares for, on average, 173 patients daily and 63,000 patients annually. The power analysis indicated that there should be 64 patients in the previous stroke protocol group and 64 patients in the revised stroke protocol group. Only a total of 95 patients met the inclusion criteria, 51 in the previous protocol group and 44 in the revised protocol group. Inclusion criteria included patients who were 18 years of age and older and presented to the ED between January 1, 2020 and February 28, 2021. This time frame allowed the researcher to obtain and review records to compare the two stroke protocols to determine if the revised stroke protocol improved the treatment time of stroke patients. The patients who were included must have had documentation of an acute ischemic stroke or hemorrhagic stroke in the chart or have been documented as being activated as a code stroke. The onset of acute stroke symptoms was either less than 24 hours prior to arrival or unknown because these were the requirements to activate a code stroke at this facility. Inclusion criteria consisted of patients under the age of 18 and those who presented to the ED prior to January 1, 2020 or after February 28, 2021. Patients with an onset of acute stroke symptoms greater than 24 hours were also excluded. No patient recruitment was utilized for this project because it utilized a retrospective electronic chart review. The facility's IT department provided the researcher with a list of patients who had a stroke between January 1, 2020 and February 28, 2021. The extracted data comprised the minimum necessary data to achieve the goals of this project. At the completion of the data collection, the researcher returned the list to the ED director to be destroyed. Data collection instruments included the data collection sheet that I created specifically for the study. I recorded the minimum necessary data to accomplish the goals for this project, and no patient identifiers were extracted from the electronic medical records. The data collected to evaluate the door to CT time, door to TPA time, CT to CT read time, and the critical care time was analyzed using the Mann-Whitney U-test with an effect size of 0.05. The Mann-Whitney U-test was used to determine if there was a statistically significant difference between each of the above timeframes from the previous stroke protocol to the revised stroke protocol. An upper tail z-test for the difference of two proportions was used to determine if there was a statistically significant difference between the frequency of TPA administration between the two protocols. The total sample consisted of 54.7% female patients and 45.3% male patients. Here you can see the genders of the two groups separately. The first pie chart is the previous stroke protocol, and the second one is the revised stroke protocol. The ethnic background of the sample included 60% African American, 28.4% were Caucasian, 7.4% were Hispanic, and 4.2% were unknown. This figure shows the ethnic backgrounds of both groups separately, and again you have the previous stroke protocol first and then the revised stroke protocol. There were reductions in the door to TPA times and critical care times of the revised stroke protocol when compared to the previous stroke protocol, but the main Whitney U test revealed that these reductions were not statistically significant. The door to CT time did not decrease with the previous stroke protocol. The main Whitney U test did reveal a statistically significant decrease in the CT to CT read time of the previous stroke protocol to the revised stroke protocol. So it can be concluded that the revised stroke protocol resulted in a statistically significant reduction in CT to CT read times. Here we have a chart of the time frames of the two protocols. In yellow we have the CT to CT read times. The revised stroke protocol had an average of 11 minutes for the CT to CT read time, and the previous stroke protocol was 19.8 minutes. In orange, you can see just a slight reduction in the critical care time between the two protocols, and then in red you have the door to TPA time, which is again lower in the revised stroke protocol. The upper tail z-test for the difference of two proportions revealed that although there was an increase in TPA administration from the previous stroke protocol to the revised stroke protocol, this increase was not statistically significant. Here's a chart showing the TPA administration frequency. First shows the previous stroke protocol at 7.84%, and then the revised stroke protocol is 13.6%. Of all stroke patients received TPA. This study established the importance of the implementation of a stroke protocol utilizing strategies from the 12 key best practice strategies of the American Heart Association, American Stroke Association's Target Stroke Initiative. The revised stroke protocol resulted in reduced CT to CT read time, door to TPA time, and critical care time, as well as an increase in the frequency of TPA administration when compared to the previous stroke protocol. These results supported the aims of the study. Door to CT time did not decrease from the previous stroke protocol to the revised stroke protocol, and only the CT to CT read was statistically significant. The results of the study allowed the researchers to conclude that the revised stroke protocol, utilizing strategies from the observed outcomes did not quite match the expected outcomes. The observed outcomes only resulted in minor decreases in the timeframes of the door to TPA and critical care time, and a slight increase in TPA administration frequency. These differences were not statistically significant. There was also a small increase in the door to CT time from the previous stroke protocol to the revised protocol, which was not expected. The only outcome that resulted as expected was a reduction in the CT to CT read time. Various factors could be responsible for the observed outcomes not meeting the expected outcomes. Multiple changes were made to the stroke protocol, and each change could have influenced the outcomes. It is difficult to determine which change had an effect, though, since multiple changes were made at once. One possible change in the revised stroke protocol that would have had an influence on the door to CT time would have been that acute stroke patients were taken to the trauma resuscitation bay upon recognition of the acute stroke. In the previous stroke protocol, the written protocol stated to take patients to an exam room. But a verbal change was made that asked staff to take the patient directly to the CT scanner. Since this change was not written, the previous stroke protocol was not always carried out in the same way. But since some patients were taken directly to the CT scanner, this could be why patients treated under the previous stroke protocol received their CT faster than the revised stroke protocol. Another change in the revised stroke protocol was the implementation of a CT scan for all ischemic stroke patients. This scan occurs after the CT non-contrast scan. This scan could be a potential delay due to the need for intravenous access and the need for time to complete the scan. Inserting the IV and completing the scan would have added time to the care of the acute stroke patient. It would have potentially increased the critical care time and TPA administration time. One other change in the protocol was that the patients were taken back to the trauma resuscitation bay after the CT scans. In the previous stroke protocol, the patient was taken to a regular exam room after the CT scans. This means that some of the remaining tasks were completed by the nurse of the patient instead of the stroke team. Since the patient was taken back to the trauma resuscitation bay in the revised stroke protocol, these tasks were completed by the stroke team. Depending on how critical care time was recorded, these tasks were more than likely included in the critical care time of the patients of the revised stroke protocol and not the patients of the previous stroke protocol. This would have increased the critical care time of the patients treated under the revised protocol. Other factors could have been related to the COVID-19 pandemic, which I will discuss further under limitations. One limitation of the study was the sample size. Although there was a moderate sample size, the goal was to obtain 64 patients for each stroke protocol group, a total of 128 patients. The study did not meet this goal. There were 51 patients in the previous protocol group and 44 in the revised protocol group, a total of 95 patients. Another limitation was that the data was gathered by retrospective electronic medical record review. Data collection relied on information from the EMRs. Timestamps in the charts were used to determine when various tasks were completed, for example, when the CTO was obtained or when TPA was given. These timestamps may not always be correct. Nurses' notes were also used to determine these times, and some of the timestamps in the nurses' notes did not match the timestamps in the chart for various tasks. In the revised protocol, live reads of the non-contrast CT scan of the head were completed. The time these scans were read were not always documented well in the chart, but the read time could be inferred by when the CTA scan was started because it would occur right after the live read of the non-contrast CT scan, if the non-contrast scan did not reveal a hemorrhagic stroke. The recording of the critical care time for each patient was also a potential for inaccuracy. For the previous stroke protocol, the organization of care of the acute stroke patient was not always consistent. This resulted in poor documentation of the critical care times because the protocol was not always followed as written. A third limitation of the study is that all of the data was collected by one researcher. Errors in the data collection could have occurred, and there was not another researcher to check the data collection for errors. As the researcher, I took care to obtain data accurately and reduce possible imperfections in the data collection. Another limitation is that the list of acute stroke patients who were activated as a code stroke was reliant on information technology or the IT department to be able to search the charts and locate these patients. It could be possible that some acute stroke or code stroke patients were not found in the search. A major barrier to this study was the COVID-19 pandemic. There were delays in the implementation of the revised stroke protocol. These delays were worsened by the COVID-19 pandemic. A new protocol must be approved by several people in order to be implemented. The process to approve the new protocol had begun prior to the COVID-19 pandemic, but delays in the process occurred once the COVID-19 pandemic started due to administration staff members working from home or being reassigned responsibilities to help with the pandemic, which limited their abilities to complete their normal responsibilities. Since there was a delay in implementing the revised stroke protocol, this could have impacted the length of the time it could be researched by this study. Data was collected from patients treated under the previous protocol for a period of 8.5 months, but only 5.5 months were available for the revised stroke protocol. This would have also impacted the sample size for the patients treated under the two stroke protocols. The COVID-19 pandemic caused a large reduction in the overall census of the ED of this facility, as well as the number of stroke patients treated. In 2019, this ED saw on average 178 patients daily. This number decreased by 20 patients a day to an average of 158 patients per day in 2020. The number of code stroke patients also decreased from 2019 to 2020. In 2019, there were 34 more code stroke patients than in 2020. The COVID-19 pandemic also resulted in process changes in the ED. Anytime a patient was brought to the trauma resuscitation bay for care, the staff were required to don full PPE, including gloves, gown, surgical mask over an N95 mask, and a face shield. Since the new protocol required code stroke patients to be brought to the trauma resuscitation bay, delay occurred from donning full PPE when previously full PPE was not required for stroke patients. Also, due to the pandemic, less staff were allowed in the trauma resuscitation bay, which could have led to delays in patient care. Another process change was that there was no visitors were allowed with ED patients. This could have resulted in delays in recognizing acute strokes in patients due to not having information from friends and family of the patient's baseline. It also became more difficult to determine a patient's last known well time without the input from friends and family. The COVID-19 pandemic did have an effect on both the previous protocol group and the revised protocol group, since the revised protocol was not implemented until September of 2020. In conclusion, this study found that the revised ED stroke protocol in a large revising the stroke protocol in a large metropolitan area non-stroke center hospital to include best strategies from the 12 key best practice strategies of the AHA-ASA Target Stroke Initiative resulted in improved door to TPA time, critical care time, and CT to CT read time, as well as an increase in the frequency of TPA administration. The revised stroke protocol will continue to be used and will be monitored to assess for consistency. Changes may be made to the protocol in the future to further improve acute stroke care. The revised protocol will continue to be used at the facility of the study to further improve assessment, stabilization, and treatment time of patients with a suspected acute stroke. Here are my references. Are there any questions?